In this segment, we are demonstrating the video endoscopic evaluation of the swallowing mechanism. We have a perfectly healthy volunteer here with us to demonstrate to you the normal deglutitive mechanism. Transnasal, unsedated video endoscopic evaluation of the swallowing mechanism will show us several components of the swallowing. Most importantly, it can determine whether aspiration or penetration exists. It also can tell us about the presence or absence of hypopharyngeal residue. In some cases, one may be able to test premature oral spill into the pharynx. But the main utility of this technique is to define the safety of swallowing, i.e., if there is aspiration, then we have our answer. Now, for this procedure, we do not use any anesthetics. Simple lubricants such as KY jelly will do. The endoscope is quite small, has an outer diameter of 3.1 millimeter. This is basically a laryngoscope, and as such is handled a little different than the upper endoscope. Most individuals tolerate passage of this small caliber endoscope through the nasal cavity very well. So again, I will hear the patency of the, they both sound equal to me. We will try to stay at the floor of the nasal cavity. We are passing between the inferior turbinate. We just cleared the nasal cavity, looking at the nasopharynx. Are you okay, Chuck?
Yes.
And we are going to advance down the, yes, he swallowed. Pretty good. Advancing down to the pharynx. Because we have not used any numbing material, the pharynx obviously is very sensitive. Chuck, could you reach up and grab the scope next to your nose? Just hold it there, don't let it in or out, so I can adjust the view a bit. That was a good swallow. Okay, now we are much more clear. Okay, I got it. So we are looking at the epiglottis, as seen here, the vallicular space, the back of the tongue, and of course the glottis is seen down below. If we could get closer to it, Chuck, withhold swallowing. Here we go. Don't swallow, don't swallow. So we have the cords, and we have the arytenoids, and we have the piriform sinus on both sides, posterior pharyngeal wall. And if I hold the scope steady here and ask Chuck to swallow, swallow, Chuck. Very good. So now let's see if we could have him swallow some colored material so we can observe its passage through the pharynx. Now, Chuck, hold this colored fluid in your mouth as long as you can. So I am now looking at the closure of the oral cavity and its separation from the pharyngeal cavity. You see the uvula just coming into the view, and the tongue base is elevated. The soft palate has touched the posterior tongue. He is losing some colored material coming into the vallicular space, as you see here. Now I will go back and hide behind the soft palate so the tip of the scope doesn't get colored, and I will ask Chuck to swallow only once. Very good. And then I immediately advance and have a look at the area. As you notice, we do have coloring of the entire pharyngeal cavity, indicating that they came in contact with the green swallowed material, except that the laryngeal vestibule, as you see, has not come in contact with the swallowed matter. The green color is seen right at the edges, and that's about it. So this is a normal swallow, and he has quite a safe and protected deglutive apparatus. Now let's do some mashed potato swallow that can simulate a chewed food. Yes, go ahead and swallow. Nice job. He has some oral residue that dripped into his follicular space. That's quite normal under normal eating conditions. You may want to swallow one more time, Chuck. Very good, very good. So we go back and interrogate the area, follicular space clean, and piriform sinus on this side is just barely stained, and on this side the same. And the cords are clean, and the inside the trachea is quite clean, and I don't see any residue. Could you kindly give us an E, a long E? See that cord is functionally intact, so it can adduct normally. Thank you, Chuck. And now could you bear down like a Valsalva, like moving your bowel? Just, yes, that's a Valsalva maneuver. Relax. Do it again. You see the cords close, and then the adducted arytenoids seen here goes to the base of epiglottis. So you have two tier of closure. Relax. Very good. So if you have a patient that may have some deglutive problem, you could have them do a mini Valsalva and then swallow. By doing that, your cord is very well protected. I think we are almost done here. Coming back into the nasopharynx, base of the skull straight through. You have the eustachian tube opening, and this side coming into the nasal cavity and exiting. Very good. Excellent job. Thank you.